Stage 3 melanoma is where the tumor has gone into a lymph node from the primary site, or it's a case where there are in-transit metastases, which means the area of the primary, a little bit distance from that area, maybe 1, 2, 3, 4 centimeters, there are cutaneous nodules that are melanoma that spread from the primary to a place a little farther away in the skin. And so that's the, stage 3 melanoma. And stage 3 melanoma has a, relapse rate of about 60 to 70%, depending on other characteristics of the tumor, like if there's ulceration in the primary, which is an adverse prognostic factor. Patients with that will have earlier relapse and earlier death. So the traditional approach was to just remove things surgically and then observe people. And because there is this high relapse rate, when we did finally have some success with stage 4 melanoma therapies, and that being BRAF, MEK inhibitors, and with Keytruda and nivolumab, which target PD-1, block PD-L1 binding to the T cells, those were effective in improving survival for stage 4 melanoma patients, and survival improved from an average of about 10 months to 5 years. Half of people are now alive at 5 years with stage 4 melanoma. So this has actually been the largest improvement in survival outcomes of any cancer in history, except for maybe when testicular cancer was cured when we introduced cisplatin into the treatment regimen. So the concept in oncology is usually to transition drugs that are working well in stage 4 into stage 3. And so the clinical trials were carried out and demonstrated that BRAF inhibitors, brafenib and trametinib, as well as Keytruda and nivolumab, would improve survival for stage 3 patients when done after resecting the tumor. And so that's really kind of where we are at. And then the question is, do you want to give immunotherapy before you resect the tumor? And I have some patients, they couldn't really go through the surgery for stage 3. I have treated them with Keytruda, and surprisingly, they did really well. And SWOG did a trial looking at that question of giving the Keytruda before you do the surgery. And those patients did very well in that trial. So that's kind of how we're looking at it now. And the question is, if you give the immunotherapy before you remove the tumor, you have an advantage of the cells you're trying to help kill the cancer. The T cells are in the tumor. They're tumor infiltrating lymphocytes, and they're living with the cancer cells and trying to kill the cancer cells. And if you take the tumor out, those cells are taken out of the body, and those are the ones that see the cancer and are reacting to the cancer. They got there. And so having them present when you give immunotherapy makes a lot of sense, because you have the activation of the cancer in terms of activating the T cells with their foreign antigens, and you can give a shield to the killer T cells in the form of a PD-1 inhibitor, which protects it from the killer PD-L1 molecule, which is like a sword that sticks out of the cancer cells. That was Hanjo from Japan won the Nobel Prize for discovering PD-L1. And I think it's great. This Japanese guy figured out the sword that sticks out of the cancer cells that kills the T cells. So, that's kind of the rationale for the moving immunotherapy into an earlier stage of intervention. Again, it's the concept of moving things earlier if they're effective, but in this case, not an earlier stage, but an earlier point in intervention for the patient. So the concept, again, is that if you leave the tumor intact in the patient and then give immunotherapy, will that be better than if you take the tumor out and then give the immunotherapy. So neoadjuvant immunotherapy before surgery versus adjuvant immunotherapy after the surgery. And the question was answered by doing the clinical trial, which was randomizing people to get ipilimumab and nivolumab, two immunotherapy drugs. Nivolumab targets PD-1 and ipilimumab targets CTLA-4. So two checkpoints that would be turning off immune responsiveness. And they only gave 2 cycles of the ipi-nivo in the neoadjuvant arm, and the other people would get surgery and then the standard ipilimumab or nivolumab. So like the SWOG trial looked at Keytruda, and this trial is looking at ipi-nivo. So they got 2 courses of ipi-nivo, and then after that they'd go to wide excision of the tumor and lymph node dissection. And then the people that were randomized to get the surgery first, then they would go on to 12 courses of nivolumab, and they could get radiotherapy also if that was indicated. So that was the study design. So stage 3 patients with measurable disease on CT scans was one of the criteria, because they did use imaging, PET-CT, CT, to see if the tumor was responding, in addition to when the tumor was removed after 2 cycles of neoadjuvant immunotherapy, it was looked at under the microscope to see if there were still cancer cells present or not. And then the study compared the pathology response versus the radiological response. So that's the design of the study. And so the primary endpoint of the study was event-free survival, progression-free survival from time of randomization. And then the secondary endpoint was overall survival. And then they measured pathologic response rates. They measured recurrence-free survival, distant metastases-free survival. And then, of course, adverse events and surgical complications. And I think one of the interesting things was they did compare the pathologic response with the radiological response and found quite a big disparity. And in the study, if you did have a major pathological response, you didn't receive any further therapy. But if you didn't have a major pathologic response, which would be a complete response or a near complete response, then you would get additional treatment. So it was really interesting, because I think we do give, we just keep giving it many times, and probably we're giving it too much in some cases. And so this kind of looked at the question of, can we stop after just 2 cycles? And if they've had a complete response, or, not. And so the outcome helps us understand that 2 cycles was enough to achieve a really great success. And because the treatment can be toxic, limiting to 2 cycles is very favorable for the patient in terms of quality of life. So, they had 212 people that were put on the neoadjuvant arm and 211 people on the adjuvant arm. And they were very similar in their makeup. And the primary endpoint, event-free survival, was significantly better. At 12 months, the event-free survival was 83% in the treatment arm versus 57% in the adjuvant arm. So they had a reduction in risk of recurrence or an event. It reduced it by 70% per year, which is huge. So, and then as they followed people out to past 2 years, there was a flattening of the curves where it looks like, people were in durable remission. And so the expected recurrence rate will be low as time goes on past 2 years, which is what we see in the clinic for stage 4 patients. And so of the people that got the neoadjuvant therapy, the major pathologic response rate was 59%. So 59% of the patients only needed just 2 cycles of immunotherapy in a neoadjuvant setting, versus the patients who got it adjuvantly, they're getting it for a whole year. So, and interestingly, the radiological findings did not mirror the pathology findings. So the radiology was, calling people progression in maybe 20% of the people, whereas they had stable disease or they had a response. So I think that we were also taught by this study that you really need to look at the pathology rather than the radiology to see how somebody does after neoadjuvant treatment. The overall clinical implications, the hypothesis was proven to be true, which is if you leave the immune cells in the tumor, in the body, and then give the therapy versus taking it out and then giving the therapy, having those present together when you give the immunotherapy, it significantly improves the immune response to cancer. So that's, and only having to do 2 cycles is huge in terms of quality of life for patients. And that's the neoadjuvant people, 60% only needed 6 weeks of treatment and they were done, versus a whole year if you went on the adjuvant route. So I think in terms of the subsets of patients, basically almost all subgroups benefited from the neoadjuvant therapy. So it isn't like only a certain subset benefited from it. Everybody benefited from it. And now it has already been put into the NCCN compendia. So I think this is going to be the new standard of care for stage 3 melanoma.